Okay, so the next slide is an amnio infusion. It's something that we can do if we need to replace some of the amniotic fluid. You can either use normal saline or lactated ringer, and we do it in case there's any problems with fetal heart rate, like utero-placental insufficiency. So if you see those late decels, if we see premature rupture of membranes and we notice that there's not a lot of amniotic fluid enough to keep that baby safe, then we will give an amniotic infusion or an amnio infusion. Anytime you see a post-mature fetus, we're trying to prevent meconium aspiration. So if we can instill more fluid to make the amniotic fluid that has meconium in it less dense, so there's less risk. If they do aspirate, they will get less meconium in there. We can do that. And then if we see that the baby's lying on the cord, we can reduce the cord compression or those variable decels by giving an amnio infusion. Okay, I missed one there. Okay, so with dystocia or failure to progress, sometimes we'll need things to assist in the birth. And the first one is forceps delivery. They don't use this a lot anymore. They are more prone to use the vacuum, and this is because they're trained on it. And it might be that it's safer. I really don't know the answer to that. But the cervix has to be completely dilated and the fetal head has to be engaged in order to do this. There are lots of risks with the forceps. As you can see, a cephalohematoma, which is a hematoma that's very superficial and can resolve on its own. It's not such of a problem. Caput succedaneum is, this right here is just the edema, the swelling of the head that every baby that is vaginally delivered has. So these two things are normal findings, and it can be increased with the forceps delivery. You can cause any kind of nerve damage. This brachial plexus nerve right here is the shoulder, going from the neck to the shoulders, if you could imagine it right here. So if you're pulling on the head and the shoulders are stuck, then you can cause tearing and shearing of those nerves in that brachial plexus, or any in the craniofacial. So any craniofacial nerves you can cause damage to by using the forceps. You can cause lacerations and bruisings. If you push too hard, you can cause skull fractures. And then the real thing skull fractures is a big deal, but intracranial hemorrhage is probably the biggest risk factor. And then you can cause lacerations to the mom as well. So what you'll see more often is the vacuum extraction. And you can see right here, it's just this cap-like device that has a suction hooked up to it. And it applies traction, and you're just kind of pulling along the baby's back of the head, the occipital bone. So what happens is if they pull really hard and the baby's unmoving, you have what's called a pop-off. So these pop-offs can cause cerebral hemorrhaging if you do it too often. So doctors or providers, midwives I don't believe use these, but they're only allowed 3 pop-offs before they should do a C-section because of that risk of the hemorrhage. So we want to monitor that fetal heart rate as we're doing this. I think we talked about this in lab. This is what is called an episiotomy. It's where they cut an incision either mediolaterally or midline to help open up the vaginal open when a baby is coming through. So this is something that they don't practice anymore, and studies have shown that a repair of an episiotomy can actually decrease the strength of that perineal floor, which is what women need to keep bladder control, to keep the uterus from, coming out later on in life. And so when women get these episiotomies, especially repeated, so multi-gravida women that have had these episiotomies, it can cause problems to them later on in life. And so what they actually are doing now, and the newer providers are being trained this way, is to sort of take some mineral oil or some essential oils and massaging this tissue right here to really loosen up this as the fetal head is descending, so that there is less risk of tearing, and to let women tear on their own, because how the skin heals itself after a tear is much stronger and creates a better perineal floor than if the woman were to be cut with an episiotomy. But we still need to, for this class, and for tearing, this is the same as tearing or episiotomies, how we care, how we teach them to care for this incision or this tear. So with really extreme tearing, and we'll talk about that with postpartum, what those different lacerations look like, they're going to stitch. They're going to surgically, not surgically, but stitch those tears up and repair that woman the best they can. But for the nurse, we're going to provide ice packs during that first 24 hours. So only during the first 24 hours we apply cold to those incisions to really numb the incisions up and help decrease the pain. Then the sitz baths. So sitz baths are just warm water. You can put some solutions in it, like I can't think of the word right now. Hydrochloride. Doesn't matter. The sitz bath is just a warm water, and the woman kind of sits in it. It's nice. They can use like a donut if they want, which is just a little round pillow to kind of prop them up so it's not so, heavy on where they're sitting on, and really just sitting in that warm water with hydrogen peroxide. That's the word I'm looking for. Hydrogen peroxide or some other kind of ointment to help heal those incisions or those tears. With postpartum on our unit, we put together a really nice kind of situation for them. We do a peri pad, then we do an ice pack, and then on top of the ice pack, we put these analgesic pads, which is made of kind of a numbing, and it also helps heal the wounds after women have had a baby. So, and then we just have them sit on it, and they love it because it gives them the cooling factor, it gives them the numbness that they get, and then they can not feel so much pain. And we also give them pain medications if needed. So we're going to teach them perineal care, wiping front to back and using their peri bottle, which I'll explain that in the next, in postpartum. And then we're only going to let them shower, because remember, this is an open incision, and bathing is going to cause problems, can cause organisms to, infect the uterus or the vaginal open. And then we're going to report any kind of bleeding, discharge, or edema right in that area. I guess it's on this slide that I do this, but these are what the different degrees of laceration. So the first degree laceration, you can tell, just cuts through the vaginal membrane. And then second degree goes through and just cuts a little bit deeper, tears a little bit deeper. Third degree opens into that anal sphincter. See that anal sphincter right there? And then the fourth degree goes all the way through into the rectal mucosa, you can see right here. So fourth degrees are a pretty big deal, and they are extremely painful from what I hear. And these need to be surgically repaired. And all of them are going to be stitched, but these ones are going to have a lot more intense kind of repair. And then cesarean delivery, this is what we possibly need to, if there's complications and there's no way to vaginally deliver this baby. I have a C-section video. It's delivery of twins that you can watch. And this is a horizontal incision you can see right here. And we just want to make sure that that woman is laying supine after she gets her spinal block, and her wedge is under one of the hips, so it places the right hip, so it kind of places her left to be perfused. So pause this video if you like and watch that C-section video. It's a pretty interesting video. One of the babies is born breech, and so you can see this number 2, baby B, his feet are up in pike position for a while. And that's when breech babies are born. They'll kind of favor that pike position for a few days afterwards. Okay, so we're going to continue into labor and delivery complications just because I have about 5 more minutes. The first is umbilical cord prolapse. We've kind of talked about this. When we talk about ruptured membranes, we always want to check to see if that umbilical cord has not come down and going to be cut off during a contraction by the fetal head. This occurs at ruptured membranes or soon after that, and it will cut off their blood supply, like I said. So this is an absolute obstetrical emergency. And what happens when a nurse is doing a vaginal exam and she finds that prolapsed cord, she will find the cord having its own heartbeat. And once she does, she will not leave that patient behind. So she will stay there and apply counterpressure to the baby's head. And she will push the call light, and she will keep pushing on that fetal head. She will go with that patient as they roll that bed into the delivery room to do the C-section. And she will not relieve counterpressure off that head until that baby is delivered via C-section. Because remember, that baby is not getting oxygen at all. So this is something that the mom will stay the nurse will just stay with the patient until that baby is delivered. So you can try to reposition the mom, do kneaded chest, Trendelenburg, or side lying type of thing to help with the situation, but the nurse is going to stay with that patient until that baby is delivered. So with meconium stained amniotic fluid, this is usually for a stressed baby that's post-dated or having some sort of uteroplacental insufficiency. They're not getting the oxygen that they need, or the placenta is getting old and is not as useful, is not as good as it has been in the past. So stop being able to it's just not working as well. I can't think of the right word, but so this is just that passage of that first stool in the amniotic fluid. So the baby will come out green. And if we see green amniotic fluid, then we know during the delivery that the NICU team is going to be there, because they're going to have to decide what kind of resuscitation measures that baby is going to need. So this is the latest NRP sort of guidelines are that we're not going to suction that baby unless you see a fetal heart rate less than 100. And if that fetal heart rate is depressed, then we're going to suction. And we're always going to suction that mouth first, then that nose, so that they won't aspirate the contents of their mouth when we suction their nose. And then we may need to just do a quick intubation, suction below the vocal cords, make sure we get all the meconium out if we determine that there is a risk of aspiration. So that is the latest NRP protocol. The next two are the dysfunctional labor patterns. So this is the hypotonic. They're not strong enough to cause change to the cervical membrane. And so with this, we want to assist with position changes, maybe rupture membranes, because rupturing the membrane will cause the contractions to become stronger, more effective. Maybe start some oxytocin. So an amniotomy is rupturing the membranes right here. and then the hypertonic, which are these strong contractions, but they're not coordinated, so they're still ineffective at dilating and effacing the cervix. And the most important part is they're not getting this complete uterine relaxation between contractions. So we want to calm the mom this time. So reduce environmental stimuli, turn off the lights, hydrate her, give her maybe some pain medication or sedation, and give her a warm shower or bath. All right, we're going to stop this video and go to the